Welcome to our live webcast, the latest in total joint replacement, including CJR, Medicare changes, and patient optimization for surgery. Thank you for joining us. My name is Juliet Davis, and I'll be the operator for today's program. Before we get started, I'd like to take a moment to briefly acquaint you with a few features of this web event technology. At any time, you may adjust your audio using your computer volume settings that you may have. On the right-hand side of your screen, you'll see a text chat window. There's a large window which holds all your sent messages, and a smaller text box at the bottom where you can type in your questions. To send a question, click on the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order which they were received, and they'll be addressed at the end of the presentation. At the conclusion of today's program, we ask you to complete a brief post-event survey. Please take a moment to complete this in order to receive credit for attending and providing feedback for the webinar. We are joined today by our speaker, Dr. Jeffrey Leary. At this time, I'd like to turn the microphone over to our speaker, Dr. Leary, for opening remarks.
Great. Thanks, Juliet. And thank you, everybody, for joining. I appreciate it. Like she said, we will be taking questions at the end. I'm happy to answer questions during if something comes up that you want answered right away, and I'll try to address them in a timely fashion. The topic tonight, the latest in total joint replacement, including CJR, Medicare changes, and patient optimization. At first glance, doesn't seem super exciting, but this is a topic that is super pertinent across all specialties, and I'm going to try to make it as informative as possible, and hopefully everybody learned something tonight. So as we go forward, I just want to take a look at a brief study that was done a couple years ago looking at the prevalence of severe arthritis among the population here in the U.S. And I just really want to point out that you really start seeing a big jump at a fairly young age, and probably younger than most people realize, that around the 45 to 55 mark, the number really starts to skyrocket, a little more prominent in females than males. And by 55 to 65, you see a huge spike there. So really from 45 up is really when this becomes most prevalent, but even at the younger age of 35, you start seeing a gradual incline. So we are seeing this at a fairly young age, and then right in that middle age baby boomer population, we start seeing a big spike in the current demographics in the U.S. This next slide is a study that was done about 15 years ago now, and it was a projection of what we could expect as far as the need for total hip and total knee replacement in the U.S. population over a 30-year span. And you see right now we're in 2020, right in the middle of that. And you see right about here that the number even in the last 10 years has doubled. And if you look at what's projected to happen in the next 10 years, it's supposed to double again for the need for total knee and really go up again for total hip. And a lot of that has to do with the patient population as the baby boomer generation is getting older, as well as younger patients coming up with more arthritis. There's going to be upwards of 3 million total joints done in the next 10 years per year, and that's just an astronomical number. And when you have numbers like that, again, these are patients that all of us are going to be seeing regardless of specialty. So this really is a topic that's relevant and pertinent to all docs across the spectrum here. So why is this important? So with the dramatic increase, what we're seeing every year, doubling, tripling in the next decade, we're seeing again in younger patients. And to go along with that, you know, the patient population is more educated, more active, and the expectations of what we're able as orthopedists to provide with these operations has really changed in the last few years. So patients have a different expectation regarding the surgery, how long the surgery is going to take, how long they're in the hospital, how much pain they're going to have, how long the joint will last. They expect to be recovered in a quicker amount of time. They want to be back home. They want to be back to work. They also want to be able to have high activity levels. This is no longer an operation for grandma and grandpa where you're just going to be able to walk down the driveway, get your newspaper, get your mail. Patients want to be able to ski and run, do triathlons, CrossFit, all these things after hip and knee replacement. So us as surgeons need to be very up to date with current techniques and current implants and being able to sort of keep up with the patient expectations. The other thing that has changed dramatically in the last 5 to 10 years is the payment models. And we're going to talk about that tonight with the CJR, the bundle payments, because this has gone and become a real outcomes-based, quality-based operation. It's not just based on volume, but it really is very much based on how patients perceive their outcomes and how well they're functioning and how much quality we're able to provide with these operations. So with that as an introduction, the three topics I want to touch on tonight is sort of what is the latest in total joint replacement, sort of the latest in technology, techniques, what have we seen change, and what do I think is the most influential in the last couple of years. From there, we're going to segue over to the CJR program, which is the Comprehensive Joint Replacement, or quote, the bundle. And then we're going to finish up looking at patient optimization and what effect this has on joint replacement and final outcomes for the patients. So as a quick review, why we're talking about this, what is arthritis? And that's a loss of cartilage in the joint. Normal joints have articular cartilage, which provides your bearing surface. You see a normal x-ray there. When the cartilage wears away for a variety of reasons, whether it be osteoarthritis, which is your wear and tear, versus rheumatoid or avascular necrosis, post-traumatic, inflammatory arthropathies, things like that, cartilage is lost, leading to deep inflammation, pain, deformity, loss of joint space, which you see in the x-ray there. The same thing goes for a hip replacement or hip arthritis leading to hip replacement, where you have severe arthritis, loss of joint space, poor function, pain, and then leading to knee replacement. And again, this is not a talk specifically about the technique, but understand that a knee replacement is essentially a resurfacing for the knee. It's a common misconception. And what that looks like there is we're just restoring the joint surface with a metal articular surface as opposed to cartilage. Same thing goes for hip replacement. We're replacing a new femoral head, new socket. And again, I'm not going to get into the actual techniques and implants tonight. That's not what this topic is, but I just want to make sure everybody understands what we're talking about when we're talking about hip and knee replacement. So really what is the newest, and this is opinion, I mean, this will vary, but in my opinion, really the three things that have changed the most in the last decade within joint replacement would be the advent of or increased use of robotic surgery, the use of the anterior approach for hip replacement, and also how well we're controlling pain with a multimodal approach, a narcotic sparing approach. Those three things, which we're going to touch on, I think are really the most influential that I've seen in the last 10 years with how we're doing joint replacements today in 2020. So what is robotic surgery? The common misconception is that there's a robot in the room, you hit go, the surgeon goes and does a crossword puzzle, and the robot completes the surgery. And it's not what it is at all. It's really robotic assisted surgery. The most common, most popular system that we're using in Atlantic Health right now is the Mako system, and it's a robotic arm assisted surgery. And what that does, what this technology does, it allows us to do patient-specific surgery with increased accuracy. And how that works is when a surgeon has selected a patient for a robotic procedure, the hip or knee, whatever it is sent. The patient is sent for a CAT scan, and we 3D model and create a virtual version of that joint, whether it be the hip or the knee. And we're able to virtually plan the operation ahead of time before the patient's ever in the OR. We build a model, plan out the surgery, how much bone needs to be cut, where implants need to go to recreate normal anatomy. And then once we've done that, the robot allows us to make those exact cuts and measurements with very, very little error. So it's more accurate on a case-to-case basis, and it's also more reproducible, meaning you can get the same result over and over and over, and it takes a lot of the variability out of the operation. So again, it's what we're able to do is build these models, and this is an example of a knee, where you see we've built the model of the knee. We're able to show where this implant will go, where it's going to sit, how it's going to interact with the bone. We can then look at how it's going to interact with the joint, how it's going to move. We get real measurements as far as degrees of varus, valgus, alignment, things like that. And then you can take the joint through, see exactly how it's going to function, look at alignment, before you've ever actually cut the patient. You can make adjustments right now at this point in the surgery. If something needs to be changed, you can make it. Put this back into the program, correct it, and then the robot will only allow us to make those cuts that we've already planned. Again, decreasing outliers and increasing accuracy. And what you see there, it gives us real feedback. You can see that it's actually going to give you some feedback up here where it tells you you're a little tight, a little loose, the alignment's not what you want, allows you to, again, correct it on before you make the cuts. And it also allows you to know at the end of the case that you've got the result that you wanted. So you leave the OR with actual data showing you that you've made the corrections that you planned at the beginning. And again, it just having more data is more information, it's power, and it allows you to have really excellent, accurate results for patients. And for an outcomes-based surgery, this is really critical. Next thing I think has really changed is the way we're approaching hip surgery. Traditionally, the most common way for years and years was the posterior approach. There really are three ways you can do a hip replacement, and there are variations on that, but three main ways. One is the posterior, or the direct lateral, or the direct anterior. The posterior approach is the most common by far here in the U.S. It's been done like that for 100 years, and we're going to talk about what that means. But there are two other approaches, the lateral and the anterior. In the last 10 years, there's been a huge increase in the use of the anterior approach. You hear about it, patients ask for it, and we'll go through and kind of explain what that means. A posterior approach, again, probably anywhere from 50 to 70% of surgeons still do it or use this technique. It requires a large incision on the posterior aspect of the leg. Once you get down to the deeper levels, you have to take the rotators off of the femur. So there's a fair amount of soft tissue damage. It does provide excellent visualization while you're doing the surgery. However, because you're taking the rotators down, there are concerns with possible early dislocation, things like that. Once you get down, you then have this exposure where you can put your implants in, your new acetabular component, your femoral component. And again, it does provide excellent visualization. This is a technique that every surgeon learns coming through residency. However, the things you do worry about is more soft tissue damage, potential for dislocation, possibly longer recovery because of the soft tissue damage, and the need for precautions, the need to protect the repairs while they're healing. So early on, you may have to slow patients down. But I think at the end, the results are still excellent if you do it this way. There's just some pluses and minuses that need to be talked about. The second way this can be done is what we call direct lateral, where we're coming in from the lateral aspect instead of the back. When it's done this way, once you get down through your abductors, which you see here in this drawing, you actually go around to the front of the hip and do the procedure through the front, so you're never touching the external rotators or violating the soft tissues in the back of the hip. So this is actually provides the most stability, meaning the least risk of dislocation if you look at the three compared to each other in big studies. There is the potential for some abductor weakness, meaning you have some weakness of these muscles while they're healing, which may cause us a limp early in the process until those muscles can be strengthened appropriately with therapy. But this is also a very good way to do the surgery, and it is more muscle sparing because you're not violating the back of the hip. The third way, and this is where I think has really revolutionized hip replacement in the last decade, is called the direct anterior approach. The actual approach has been described years ago and has been used for trauma and other procedures, but it's really become popular for hip replacement electively in the last few years. I would still say a minority of surgeons across the U.S. do it this way. However, what this procedure does is it actually utilizes an interval between two muscles on the front of the thigh, and all you're doing is finding an interval between those muscles and creating space between them. So you're not cutting them, you're just moving one medially, one laterally, and create a window. And from there, you're able to get directly down to the hip, do the surgery the same way, put the new acetabular component in, the new femoral component, close up. And really at the end of the surgery, all you're really doing is closing up their skin because you haven't cut anything else. So some of the advantages are fairly self-explanatory. Less soft tissue damage, faster recovery, less pain. You never violated the muscles in the back, so you don't worry about posterior dislocations nearly as much as with the other approach. You have the chance for earlier recovery, less narcotic use. You have less restrictions on the patient because you're not trying to protect or repair. Other advantages that you're able to use fluoroscopy live while you're working because of the way the patient's positioned. So you get real-time feedback in the OR. You're able to actually watch your implants go in while you're working. So it definitely increases the accuracy and the ability to recreate leg length, offset, technical components to make sure it's really done the way you want and everything is right before you leave the OR. So I really think this approach has changed the way we do hip replacements, and especially getting back to my initial comments about younger patients, faster recovery, the expectations. This has allowed us to get patients back sooner with less pain, out of the hospital sooner, and recover faster. So this is one way we're able to sort of keep up with current patient expectations. Pain management. Now again, this is a topic that could be an entire lecture by itself. I think in the last 10 years, with the opioid crisis we see in the U.S., and again, patient expectations, there's been a need to change the way we manage pain post-surgically. So things we've seen and new terms that we've been hearing, you hear about multimodal pain regimens, ERAS or enhanced recovery after surgery protocols. And the focus on these is getting patients up and moving quicker with less pain and with as little narcotic as possible to decrease the side effect profile of those medications. The way we do that is we really hit pain from 8 or 9 different angles between the use of nerve blocks, neuromodulators like gabapentin and Lyrica, different intra-articular injections, long-acting injections, use of Exparel, which is liposomal local anesthetic, early aggressive physical therapy and mobilization, narcotics sparing, high-dose steroids during the perioperative period, NSAIDs, things like that. I would go through my current regimen. It's not the right protocol. It's the protocol I use. But for NSAID, I use Celebrex. It tends to be more gastric protective. And I use that in the first 14 days after a hip or knee replacement. We use, the only time I use a long-acting narcotic is 1 dose pre-op. After that, we never see this medication again, but they get this in the pre-op area before they ever go to sleep, so it's already working as they come out of surgery. The use of nerve blocks, whether it be adductor canal, femoral, there's various blocks that can be used. This has absolutely changed the way we're able to control pain. The big one we're using now for total knee replacement is an adductor canal block, so it's a more distal block, so it does get your pain receptors, but it tends to spare the muscle function in the quads as opposed to a femoral block. So you get less weakness in the first 2 days, so there's less risk of falls. The patients can be up and walking comfortably sooner. And again, meeting expectations as far as quicker recovery, faster mobilization, and less pain. And then that is the pump that is actually left with the patient for the first 2 days. And it trickles in the anesthetic while they're recovering in the hospital, and that is pulled out before they go home. Some surgeons actually send their patients home with it for a few days, which is another option, and that is something you may see or hear from your patients. The use of Exparel, which is a liposomal local anesthetic, and what that does is encapsulates the anesthetic in liposomal bubbles, like soap bubbles, and these are injected locally in the incision before you close, and over a 72-hour period, those soap bubbles rupture, so it gives you a slow release of local anesthetic over a few days in the post-op period, which is extremely helpful in my opinion for helping control pain. The use of Lyrica or gabapentin, which is used as a neuromodulator to sort of calm down the nerves so they're not transmitting pain signals as aggressively. High-dose steroids, they help with nausea. They actually help tremendously get people up and moving, so especially in the post-op period. We give 1 dose pre-op and a 1 dose post-op, and we find this extremely effective in keeping down post-op nausea. I also use scopolamine patches in all of my patients so we can get them up and moving quicker and feeling really good and able to function with physical therapy. Cryotherapy is extremely helpful as well. All patients have either a knee or a hip cuff that wraps around the operated on joint, and it's hooked up to this cooler that circulates ice water continuously. Of all the things we provide, patients really, I don't want to say enjoy this, but see the benefit of this because it goes home with them. They use it for weeks after surgery. It's really effective for local pain control. And the other thing is, again, aggressive physical therapy in the in-hospital stay and then post-op. So to me, that's the biggest change I've seen as far as the techniques and pain control, as opposed to years ago where patients would get a PCA, high-dose narcotics. The side effect profile was really bad. Patients were in the hospital for days or weeks. I think that the multimodal approach has really revolutionized the way we're able to treat these patients post-op and get them up and moving quickly. So from there, I want to change topics a little bit and talk about CJR, the Comprehensive Care for Joint Replacement. This was a mandatory Medicare program which was put in effect about 5 years ago, and the goal was to increase quality and cost efficiency related to hip and knee replacement. And the reason is because hip and knee replacement are the 2 most common inpatient surgeries. We looked at that stat early in the talk. In 10 years, there's going to be up to 3 million of these procedures done a year, so you understand what a financial impact that has on Medicare and private insurances. And so this program really has a focus on trying to improve coordination of care throughout the entire episode, getting all parties involved, focused on providing a more efficient process and a more cost-effective way of doing these surgeries. And that's from the pre-op period all the way through 90 days post-op. Under the CJR program, hospitals are now responsible for the total Medicare spend. For every dollar spent for these procedures, from the index procedure through 90 days, the hospital is responsible for where those dollars are going. And also for any Part A or B Medicare spending in that period, not just the initial hospital stay. You see a list there on the right of all the various services that may include, including physician services, inpatient consults, the surgical services, the actual hospital costs, any subacute or post-admission stay for as far as rehab. All that goes into this bundle of money, and that's why we call it the bundle. And I'm going to touch on these a little later on how we can influence this to make this more effective, but all of these are included in the possible costs that are associated with these surgeries. The way it works is this. So Medicare established target prices for these surgeries, a target price for a knee replacement, a target price for a hip replacement, and these were established based on historical, regional, and hospital spends from previous years. They looked at various regions around the country, various hospital systems, and kind of averaged what the average cost should be for a hip replacement, including 90 days of care, for a knee replacement, including 90 days of care, and came up with average cost. And then what they said is the hospitals are now responsible for lowering the cost or the Medicare spend, how much they're spending per episode, and you have to keep it below the average price. They give them target prices. Now the goal or the mission that these hospitals were given is you have to now do it for less than that. And this is a very 30,000-foot view of this, but that's really what Medicare told us with CJR. And it was a mandatory program. So since it's mandatory, the question is then, well, why would the hospitals want to work hard to do this? If they're being told they have to do it, what's the incentive? So the program is based on shared savings. And what that means is the hospitals are incentivized to be successful. The better they do, the more money they spend, the less money they spend, the more money that is below the target, that money is shared with the hospitals. All right, so they're incentivized. The more money you save, the more money they get back from Medicare each year in the form of a refund at the end of the year. So when the total episode cost is below the target, the hospital shares the vast majority of those savings. However, and here's the caveat, if the hospital continues to spend more or above the target, the hospital has to pay the difference back to CMS at the end of the year. So there certainly is an incentive there financially to try to get involved and try to get costs down for these surgeries. The simple version you see on this chart, right? So on the left column, if the average, if they spend $18,000 for the 90-day spend, target price was $20, CMS will give the hospital a $2,000 refund at the end of the year, as opposed to if you spend $21,000, the average was $20, we overspent by $1,000, therefore the hospital at the end of the year has to pay Medicare back $1,000, okay? So seems simple enough, but when it comes to Medicare and federal programs, nothing is that simple. So here's the real nitty gritty. Even if the hospital generates savings, let's say you're able to save a couple $1,000s per case, the gain sharing is not guaranteed. It's not as simple as that chart we just looked at. There's also a scoring system for quality that Medicare has put into it, and the hospital has to achieve certain minimum quality performance points just to be eligible, and even more points if they want to be have a higher percentage of the savings sent back to them at the end of the year. And this rule was put in place really to ensure that hospitals maintain a high quality surgery while reducing costs, as opposed to just cutting costs, meaning do it cheaply but not do it well and not have good outcomes. So the patient outcomes are attached to this, so you can't just skimp and save money. You also have to produce a good product at the end of the day. So what that looks like is there's really three components to that quality score. The first one is the readmission and complication score, which is based on a national percentile. Then you have your HCAHPS, which are your patient reviews. The problem with this is that those HCAHPS are not just for the orthopedic floor at the hospital, they're for the entire hospital. So it really is a little bit of a setup for failure because it's not just based on the patient satisfaction scores who are receiving these surgeries, it's across the board for the entire hospital. So it really does incentivize the hospital to improve quality across the board, not just with their total joint program. However, it makes it much more difficult to get a high score if your hospital is not performing well on every single floor with every single patient survey. So It's a little bit of, makes it a little more difficult to achieve a high score. And then you have the outcomes, which are your patient-reported outcomes. The patients do surveys pre and post-op at various points in the recovery, and those scoring systems play into the final score as well. And what you're going to see here is that it's based on a composite between the complications, the patient satisfaction, and depending what percentile you end up in, you end up getting a certain amount of points for each of those based on your national percentile. You then take that score and you look at what your total score is, as you see here, and you get a rating. Is it acceptable, below acceptable, good, or excellent? And then depending what your score is, if it's low, you're not even eligible, even if you save money but have a poor quality score, you're not even eligible for a refund from Medicare. And you're actually set up for a higher percentage of that to pay them back at the end of the year. And if you end up with good scores, you're eligible for a refund, and Medicare is going to take a less percentage. So you get a refund, Medicare skims less off the top, and if you weren't to save money, they're only going to take a smaller percentage back at the end of the year because you have a high quality score. So it really behooves the hospital to do as well as possible in all three of those categories. But again, this is not quite as simple as save money, get money back. It becomes much, much more complicated when you start looking at all the outcome scores and HCAHPS and all these various scores that come into play over the course of a year. So let's come back to this little chart we showed earlier. So how do you save money, right? Because all these various things are big spends. And really the ones that are the most expensive are the inpatient hospitalization, and then what do you do with the patient post-op? Because if they are going to long-term care facilities afterwards, subacute rehabs, acute rehabs, these are big spend items. I mean, cost thousands and thousands of dollars per week. And all of those costs come out of that bundle that the hospital has set aside for each individual surgery. So these are really the targets as we look at where can we try to save money and efficiency in the system. And you have to start looking at how do you have success with this, right? So you have to address those high spend items. And it's critical that you coordinate care with all the players at every phase, meaning the surgeons, the hospitals, nursing, rehabs, physical therapists. Then the next thing is you have to eliminate waste. You have to figure out where can we possibly save money on the inpatient side, and that can be length of stay, various equipment, durable medical goods, things like that. And really the lowest hanging fruit there is reduce unnecessary utilization of post-acute care facilities. And what that means is, can we get patients home as opposed to utilizing facilities more frequently? And that saves a tremendous amount of money. I want to touch on these other points in a second, but what we did with it here at Atlantic is if you look at this graph from 2012, where we started thinking about the bundle, to 2015, where the bundle and CJR actually started, if you look at the purple and red combined right here, this was the use of inpatient, whether it be subacute or long-term care. This was the use of post-acute facilities after joint replacement pre-CJR. And this was the use of, this is the discharge home right here in yellow. Now you start looking at what we were able to accomplish over the 5 years, starting here till 2018, over the first 3 years. You see a dramatic decrease in the use of inpatient post-surgical stays, and a huge increase in patients sent home and use of home services, home health, and that saved tremendous amounts of money. So this is all part of getting buy-in from all the players, getting buy-in from your patients and the surgeons, doing a better job with pain control, mobilization, and getting patients home, and providing the appropriate home health, developing systems so we have a good system to care for these patients at home that's highly efficient, high quality, and saves tremendous amounts of money. The other thing that you have to do is for the patients who are going to rehab, you have to get buy-in from the rehab facilities. And what we did is we actually have a preferred network now that we've developed here at Atlantic of subacute facilities who understand what our goals are as far as getting patients home in an efficient manner, getting them mobilized quickly. And if you look again from where we were in 2015, average length of stay, somewhere between 17 and 20 days, to where we were in 2018, down to anywhere from 12 to 10 days. This is, again, coordinating your care, getting buy-in from those involved, and this saves a tremendous amount of money for the system and also for the patients, and it keeps Medicare viable. So it's all about coordinating care, and when that's done, you see how well this can be done, and that basically cut stays in half. Then the other thing you have to do is you got to talk about patient engagement. You have to get patient buy-in, and that starts at the surgeon's office, explaining to them the benefits of going home. There are good studies showing that there's less readmissions. Patients actually do better if we get them home, less exposures, especially in COVID time. You certainly are trying to minimize exposures to rehab facilities. Really, the goal then is to decrease complication readmission rates, because those readmissions and complications, if it's within the first 90 days, those expenses come out of the bundle. So it becomes very costly to the hospitals. So it behooves them to provide excellent home services and teams that can hopefully avoid readmissions. And it does behoove everyone to have a high quality surgery, because it decreases your complications. And the ultimate goal, again, is to drive down costs while maintaining and or improving quality. That's the ultimate goal of CJR. Then, to switch gears again and look at patient optimization, that's an easy segue, because if we're trying to decrease our complications, decrease post-surgery readmissions, infections, things like that, we need to look at what can we do on the front end to get these patients ready for surgery and give them the best chance at an excellent outcome, so we're not chasing our tails after the surgery with complications, infections, things like that. So there's numerous modifiable risk factors which have been shown that to correlate with poor outcomes and complications in joint. There's tons of research on this, especially in the last 10 years now that CJR has been a mainstream program. It's really, really important that we identify these in your pre-admission testing or whatever clinic you use for your pre-op clearances. Once identified, it's key to have a multidisciplinary approach to educate the patients, address and correct anything that's modifiable, things that can be changed before surgery. Not all of these are easily or rapidly correctable. It's not easy to tell a patient to lose weight, to get blood sugar under control, things like that. And it may necessitate a delay in surgery, but that's okay, because if you explain that to the patient and let them know it's for their safety so they have a better outcome, most patients understand that. But it's imperative that the surgeon is willing to have that conversation as well, to really ensure that the patients understand why you're delaying their surgery, so they can have a good outcome and it's not just out of convenience. And that comes again it comes back to having buy-in from all players across the board in your system, including the surgeons and the patients. So things that we look at in our system as far as pre-surgical clearance and optimization. First of all, we do screening for staff, whether it be MRSA or sensitive staff. Infections are probably the most devastating and costly complication that can happen after a joint replacement. As a joint replacement surgeon, we're absolutely crazy about preventing these. They're absolute disasters when they happen. Pre-existing colonization has been shown to increase risk in both hip and knee. There's plenty of research to show that. Staph species is probably the most common cause of a prosthetic joint infection in the U.S. And preoperative screening has been shown to be beneficial and cost-effective. So all of our patients are screened prior to surgery. We do nasal swabs. Up to 80% of staph infections may result in some studies from nasal colonization. All of our patients undergo chlorhexidine body wash for 2 to 5 days pre-op, irregardless of their swab. They get intranasal medication 2 times a day for 5 days leading up to surgery. If the cultures come back, the swabs come back, whether it be PCR culture, prior to surgery, we add vancomycin to the pre-op cefazolins. We do change the antibiotic regimen to address that as well. The strategy has been shown to lower MRSA rate related from 2.3 to 0.3% in one study. So that's a dramatic decrease in infection rate for a fairly easy pre-op regimen. Cost of the swabs is anywhere from $100 to $300, but the savings, if you prevent even 3 or 4 joint infections a year, is upwards of $250,000. So it's certainly cost effective, and from a quality standpoint and a patient outcome standpoint, money well spent. And that, again, infection is probably the most devastating complication for one of these surgeries. So anything we can do to decrease that, in my opinion, is money well spent. Rheumatoid arthritis, autoimmune diseases. Rheumatoid is an independent risk factor for infection and wound complications after hip and knee replacement. A lot of this is added on more by the immunosuppressive medications that these patients are on. They contribute to that. Not only the rheumatoid, but the medications can contribute. When you go through a pre-op clearance, it should include input from the patient's rheumatologist, because a lot of these treatment regimens are complicated. They're on cycles, and you have to understand the half-lives of these medications, when the appropriate time to operate is. The disease-modifying anti-rheumatic drugs need to be discontinued prior to surgery. I'm not going to go through each of these, but understand that each of these can cause increased infections, wound healing issues, things like that. Certain ones can be used all the way through, which you see below: methotrexate, hydroxychloroquine. I'm not going to read them all to you, but these medications are safe, but you really should be in consultation with a rheumatologist so you understand what their regimen is specifically before you just stop them. The biologics need to be stopped 2 to 4 weeks prior and should not be restarted till after at least the incision is healed, if not longer, and there's no evidence of infection, because it can absolutely lead to increased infection risk. Specific modifications, again, should be done with the patient's rheumatologist, because all these medications are on various cycles, and each one has a different sort of window of when it's safe to operate and safe to restart. And I'm not going to go through point by point, but it's important that we recognize patients who are on these medications and make sure that the appropriate time to start and stop is addressed prior to surgery. Renal failure and dialysis patients. These patients are inherently immunocompromised. They have increased healing times. There's plenty of studies that show total knee patients have increased mortality rates, early complication, increased deep infection rates, just by inherently having poor renal function or being on dialysis. Some studies have shown up to 4 times higher infection rate on dialysis patients. It's not always possible, but some patients may be better served if they're on a transplant list, having their transplant done successfully prior to talking about an elective joint replacement. And that has been shown to decrease infection. Certainly nephrology consultation is mandatory for a dialysis patient or renal failure patient, and coordinating any dialysis schedules or medication changes prior to surgery to avoid these devastating complications. Obesity. This is an epidemic in the U.S. It makes surgery very difficult. It makes the surgical approach more difficult, longer OR times, increased blood loss, larger incisions with possible, and that inherently leads to possible wound complications, slower healing times because of poor vascularity, longer recovery times, more difficulty with physical therapy, increased infection risk. Some studies show up to 7 times higher in total knee and 5 times higher in hip replacement in the morbidly obese. There are increased rates of aseptic loosening, meaning implant failure or breakage not related to infection, and certainly higher infection rates like we talked about. All of these require revision surgeries, which are devastating complications. They're much more difficult complications, huge financial strain, slower recovery, and just place a huge strain on the system as a whole, the health system. So anything we can do to avoid these complications, again, it behooves us to do so. Most surgeons nowadays have a BMI cutoff, and even some insurance companies. I get surgeries denied routinely for some of these heavy people until we can show that they've actively lost weight. There is substantial literature which shows that there's a major increase in complications with BMIs over 40. And for the morbidly obese, it's one thing to tell a patient to just go lose weight, but it's really key that you develop a multi-specialty intervention and education. We have a really good metabolic and weight loss clinic at our hospital, which we refer patients to. It doesn't always mean bariatric surgery. If you can get them plugged in with a nutritionist, a weight loss specialist, endocrinologist, things like that, it is possible to lose a significant amount of weight without bariatric surgery as well, but it does take a multi-specialty, multidisciplinary approach. But it's important that these things are addressed, and weight loss occurs prior to surgery to decrease risk profiles, because like we just showed, the complication rate is substantially higher in the morbidly obese, and we really need to avoid complications. Diabetes. The effects of poor glycemic control, again, are well known. I'm not going to lecture on that. This is a 20-foot, you could lecture on days for the complications of diabetes. But blood sugar control is a modifiable risk factor. Glycemic control should be well documented prior to surgery. Most surgeons have some sort of A1C cutoff. Personally, mine is 7. Other guys in the community use 8. There's not a right or wrong there. Studies certainly show, however, that tight glycemic control absolutely correlates with wound healing and infection. So it's critical that a patient has well-controlled blood sugar prior to surgery, so we are avoiding complications. Things that can be modified should be modified on the front end, not the tail end. Anemia should be addressed. It's been shown to correlate with increased length of stays, increased infections, increased transfusion rates, and increased mortality. prior to surgery, the underlying cause should be identified, whether it be iron deficiency or B12 deficiency, all these various possibilities for anemia. It needs to be addressed. Hematology should be consulted. And again, these should be corrected prior to surgery, so we're not being forced to transfuse patients. Transfusion itself is a risk factor for infection and complication. And again, if it is a modifiable risk factor, it should be addressed prior to surgery with a hematologist in consultation. Smoking and alcohol use, these are big ones. Approximately 15% of Americans still report that they smoke daily. Specific to joint replacement, in the orthopedic literature, it's been shown to correlate with impaired healing, which can lead to implant loosening and then revision surgery. Wound necrosis, higher infection rates, up to 2 to 3 times. It also leads to poor dental and oral hygiene, which is in and of itself is an independent risk factor for infection. Smoking cessation programs really should be an integral part of a pre-op program for any place that's doing a high volume of joint. Recommendations are really that it should start 6 to 8 weeks at minimum prior to surgery, so the effect of the cessation can actually be seen from a physiologic standpoint. The most effective programs should include weekly counseling sessions as well as a nicotine replacement program. These have been shown to be the most effective way for long-term cessation. Alcohol abuse correlates, again, this is in the orthopedic literature, with higher rates of stroke, infection, DVT, post-op delirium, pneumonia and aspiration, withdrawal, GI bleed, and increased length of stay after hip and knee replacement. The screening workup, there should be questionnaire that's part of the routine pre-op evaluation. If chronic alcohol abuse is identified, a professional cessation program needs to be started. I absolutely do this in my own practice. I routinely postpone surgeries until I know a patient has a documented treatment plan in place. What we've seen is, though, coagulopathies can be improved within 2 months after alcohol cessation. Wound healing capability may be restored as early as 4 weeks, and that's huge. Immune function can be improved within 4 to 8 weeks. Again, 4 to 8 weeks, therefore decreasing infection risks, which is, again, what we're all about doing, is trying to do these safely without complication. Depression and anxiety. Total knee replacement patients with untreated anxiety or depression have a 6 times higher rate of dissatisfaction, chronic pain, increased hospital length of stays, increased infection risks, and difficulty with chronic pain control after surgery. It needs to be addressed. These questions need to be asked again in the pre-op period and appropriate referrals done, because again, these are modifiable and it's not easy. This is not a quick fix like I talked about at the beginning of this topic. It may mean a prolonged postponement of surgery, but it's all about getting a really good outcome for the patient. So it's critical that we address these again on the front end, so we're not having major complications afterwards. So in conclusion, total joint replacement is one of the most common surgeries performed in the U.S. annually, and it's projected that that number is even going to double up to over 3 million per year over the next 10 years. These surgeries provide excellent predictable pain relief and improved function for the vast majority of patients. Advancements in technology and technique have continued to improve outcomes and patient satisfaction. The shift to bundled payment models has forced health systems and surgeons to work together to provide high-quality outcomes and a more efficient process in order to save money and again, improve quality and meet the patient expectations that we're seeing today. Recognizing and addressing modifiable risk factors for adverse outcomes is critical to an excellent outcome, and a thorough, robust preoperative screening and optimization program is really the key to a successful joint replacement. At this point, I'm happy to answer questions if that may be out there.
Yeah, just as a reminder, the text chat is located on the right-hand side of your screen. To submit a question, type in your question to the small text box at the bottom. When finished, click the send button, and we'll wait for some questions.
All right. Well, it doesn't look like we have any questions, so I appreciate you guys tuning in. Be happy to take email questions after the fact also. And again, thanks so much for tuning in. I really appreciate it.
Great, thank you. On behalf of Atlantic Health System Overlook Medical Center Orthopedic Surgery, I'd like to thank you all for your participation in today's present. A post-event survey will appear requesting your feedback. Please take a moment to complete the survey in order to receive credit for attending this webinar. This concludes today's program. Thank you and have a great day, everyone.